Bismillah ar-Rahman ar-Rahim. Our case is very interesting actually. It's usual in your daily practice. This case is preterm, is born at 26 weeks and requires ventilation from birth. Surfactant was given on the delivery room. Ventilation has a steady increase and the baby is in actually 95% oxygen at pressure of 28/6 at 24 hours of age. Blood gas are poor and chest x-ray in front of you now. This baby, preterm, 26 weeks, intubated, given surfactant in the delivery room. Then ventilation is steady increase and even the oxygenation requirement is increased. Oxygen requirement increased to 95% and the pressure is reached to 28/6. And the blood gas is very poor, and this is the x-ray. So the x-ray, I have to comment first about the lines. You see the lines here. This is the ATT. It's in proper position or not in the proper position. Actually, when the ATT in the proper position, why? Because the ATT, it will be 1 centimeter above the carina. 1 centimeter above the carina. What is the meaning of carina? This is the bifurcation. Bifurcations of the trachea to bronchi. If you see here, this is the ATT in the proper position. The other line here, this is big line here, or the central venous line here, actually in the right hemisthorax. It's actually it's in the proper position also, because it will be between the superior vena cava and right atrium. Any line you inserted, you be sure it's not inside the heart. Should be in the junction between the superior vena cava and right atrium. If you insert UVC, it will be between the junction of the inferior vena cava and right atrium, because if the line goes inside the heart, this is a lot of problems and complication. The one of the complication is lead to arrhythmia and baby maybe will die immediately. The second issue is may lead to pneumopericardium. It also maybe tamponade and maybe will die immediately, and also it can lead to pneumopericardium and can lead to death also. So any line, be sure, is not inside the heart. If the line is actually goes to the heart, this means arrhythmia, pericardial tamponade and pericardial effusion, and all actually is lethal and can kill your patient actually from just only the line, if you are not be sure about the line in the proper position. So you have to comment about the line during your interpretate the x-ray. So we comment about the ATT, we comment about big line, so we look for the others. So there is ossification air bronchogram. What is the meaning of air bronchogram? This is air in the airway. It will be looks like plaques and will be surrounded with whitish area because there's no air inside. So this is called air bronchogram. Air broncho like tree. You see, this is tree. You see, tree like tree. This is air bronchogram. This is classic for RDS patients. Also, ground glass appearance. It will be ossification. You see, ossification is mean whitish. Ground glass appearance. Hazy lung. It will be hazy lung, and this haziness goes to the border of the heart. The heart border is not clear. You see, this is hazy lung. The border of the heart I cannot see. Even the costophrenic angle and the cardiophrenic angle I cannot also appreciate it. I cannot visualize it. I cannot comment about it. So this is all hazy lung or ossifications or ground glass appearance, and also the last, it will be the lung volume. It's small actually. If you calculate the reps, it goes from down, it will be easy for you to calculate from down. Is actually this is 12, this is 11, there is 10, there is 9, there is 8. It's okay like this, like 7. Actually if you are need to comment about the lung volume, you have to calculate from down to up. If lung volume is less than 7 posterior, it's call it as a small lung volume. A small lung volume, this means they need to give more beep. So this is the classic picture of the RDS, air bronchogram, ground glass appearance, and decreased lung volume. Case discussion. What abnormalities are there? We said this is classic picture of RDS. Based on decreased lung volume, air bronchogram, and the ground glass appearance. What is the most likely diagnosis? This is severe RDS because the patients require more than 30% oxygen, and even the pressure he required to maintain the saturation is reached to 28/6. What is the treatment modality? For sure you have to give surfactant. So what is the abnormalities are there? This widespread of opacification throughout the post lung field, and there are clear air bronchogram in the both sides. Also the heart border is not clearly defined, and the costophrenic cardiophrenic angle are not clearly visualized. There is endotracheal tube, and there is central venous line actually entering by the left arm with the tip injunction of the superior vena cava and right atrium. This is the classic X-ray for RDS. وكانت أشعة الفلفل والملح. أنت كده جايب شوية ملح وفلفل ورميهم على منديل، مش شوية ملح وفلفل ورميتهم على منديل. So there is a small lung volume and air bronchogram. What is the meaning of air bronchogram? This is air in the airway of the lung are black in comparison to the surrounding white areas that don't contain air. This is the meaning of air bronchogram. Air inside the airway compared to other areas no air, it will be more black rather than the other, it will be tree-like picture. Ground glass appearance. Ground glass appearance, this is الزجاج المصنفر. Ground glass appearance or granular looking. So the lung were lung resembled white salt. White salt and black pepper. White salt and black pepper being sprinkled on the film. Sprinkled on the film. يعني فرق زي ملح وفلفل وفرته على منديل. The more pepper, more aeration. The more salt is more collapse and fluid. More salt, more aeration because it's black. The black is more aerations, and salt is more collapse or fluid. Diagnosis and treatment. Our diagnosis for this case for sure is RDS and severe RDS. How to manage this patient, and you have to give surfactant and conventional mechanical ventilation. If you need to scalating your action or respiratory support, you can might be put him in high frequency. So this is the management of the RDS. This is comprehensive. Actually, it's come from the European Society consensus guidelines, and actually it's summarized. This is the summary of the consensus and the guideline in the 4 items: perinatal or antenatal management, then perinatal during the delivery room or stabilization during the delivery room, and the third one postnatal, what are going to do for the baby postnatally, and lastly it will be supportive care. Very easy. I will make it just very easy. Within 5 minutes it will memorize the treatment of the RDS from your heart. Just only 4 items, put it in your mind. You have to treat the baby antenatally before the baby delivered, and perinatally during the baby deliver or the stabilization in the delivery room, and this is all NRP. We'll talk about the NRP. And lastly, postnatally, after you shift the patient from the delivery room to the NICU, what are going to do with the baby, and lastly supportive management for this baby. So we'll take one by one. Before the baby deliver, during the baby deliver, after the baby deliver, what are going to do. So before the baby deliver, this is the rule of the obstetrician. This is the rule of obstetrician, but you have to be, we are one team, multidisciplinary team. So the prenatal, first you have to the most important issues, the preterm babies at risk of RDS should be born in center where appropriate care include the mechanical ventilation is available. So any preterm babies at risk of RDS should refer him to higher center or center where appropriate care include the mechanical ventilations. You have to know your environment, you have to know your setup, you have to know your limitations. If this baby you can manage it in your center, you well and good. If you cannot or beyond your capability, you have to transfer. You have to transfer to be safe, doctor, and the transfer it will be intrauterine transfer. So any premature babies with RDS should be treated in center with appropriate care of management of RDS. If it's this beyond your capability or your limit or your NICU is limited, you have to transfer intrauterine to higher center where appropriate the care. This is the first. The second, antenatal assessment should include risk of preterm deliveries, need for maternal corticosteroid if risk is moderate or high. So this premature deliveries, you have to give antenatal steroid. For high risk or moderate risk cases, you have to start corticosteroid, whatever, betamethasone, dexamethasone, whatever is available for you, but we are preferring the betamethasone. So you have to start antenatal steroid. Why you need to start antenatal steroid for premature deliveries? To improve the lung maturation, So if you improve lung maturation, it will decrease the incidence of the RDS, or even decrease, if not decrease the incidence, it will decrease the severity of the RDS, and in direct way, it will decrease the severity of the bronchopulmonary dysplasia, and there is benefit for the intraventricular hemorrhage and the NIC and BDA and all of this. So this you have to give antenatal steroid. Another medication you have to give it antenatally, tocolytics can be used to allow for two purposes: to allow time for steroid to take effect, or for safe transfer where appropriate. So the tocolytic, there is two important, or the benefit from the tocolytic, to TT, to give time for safe transfer for appropriate center can treat babies with RDS, and also it will give time for steroid to take effective or the effect, or to take the effect. So this is antenatal steroid and also the tocolytic. The third medication you have to give it antenatally in the premature deliveries, magnesium sulfate should be given to mother with impending preterm delivery. Why we need to give magnesium sulfate for mother impending for preterm delivery? Because it will improve the neurodevelopmental outcome. This is the antenatal management. This is before the baby deliver. You have to do three things. You have to refer him to center can deal with RDS if you cannot deal with it, if you this case beyond your capability. The second issue, you can advise the obstetrician for actually antenatal steroid, and antenatal steroid will help for lung maturation, decrease the incidence of RDS, decrease the severity of RDS. In direct way, it will decrease the severity of the bronchopulmonary dysplasia, and also it will help in intraventricular hemorrhage and NIC and BDA. It's okay. The third thing, actually, you have to give tocolytic. Why you need to give tocolytic? To give time for safe transfer where appropriate place, and also it will give time for steroid effective, or the steroid it take effect. The steroid will take effect. Another medication you have to give antenatal, magnesium sulfate. We said why we need to give magnesium sulfate to mother impending deliveries: to improve the neurodevelopmental outcome of such a baby. For we are looking for the outcome, not for survival alone. Now our aim is looking for the outcome. The outcome, not matter of the survival. Survival, it's okay, but we need to look for the better outcome. This is the perinatal management. 3. Transfer for proper place or tertiary center can provide the care. You can give antenatal steroid, you can give tocolytics and magnesium sulfate. Then the baby delivered in the delivery room and the stabilization. This is NRP. First of thing, you have to tell also the obstetrician, please, you have to delay the cord clamping for at least 30 second to 60 second or 1 minute. Why you need to delay the cord clamping in the delivery room? Because if you delay, this means you will give more blood for the baby. It will give more blood for the baby. This means you are giving a blood transfusion, so will decrease the rate of the blood transfusion in the unit and decrease the rate of anemia. Also, you are giving volume. This means you will decrease the need for inotropes. It will help you to decrease the need for inotropes. But the problem with the delayed cord clamping, it will lead to polycythemia and hyperbilirubinemia. And if you have any facilities for to deal with babies with neonatal jaundice, will end good. So the first thing, you have to delay the cord clamping, and we know now what is the benefit for the delay and for how long this delaying of the cord clamping. At least will be 30 seconds to 1 minute. If the obstetrician is not help you at this time, or he missed, or he forget, or whatever, you can do cord milking, and there is actually debate, and we call it safe or unsafe. This is a lot of debate about the cord milking. Is not the time to discuss it. The second issues after the delayed cord clamping, you have to stabilize the patient, especially in premature babies, is 28-week gestation. Thermal regulation. The babies less than 28 weeks actually need thermal resources and additional resources to maintain his temperature. You have to put him, once the baby delivers, put him in the radiant warmer and prevent the heat loss. So you have to prevent the heat loss. So delayed cord clamping, then take the baby from the obstetrician, put him in the radiant warmer to maintain his temperature and to avoid the heat loss, otherwise it will be more harm for the baby. The second, you have to ventilate. Check your baby. You put in the baby in the provide warm positioning, clear the airway, dry, stimulate, reposition the baby, and assess the baby heart rate, respiration, and oxygenation. If the baby is breathing and and just only spontaneous breath with labored breathing, saturation maintain, heart rate maintain, you can connect immediately to CPAP if possible. If the baby actually is not maintain his saturation or his apneic or heart rate less than 100, you have to give positive pressure ventilation, but be careful about to avoid excessive tidal volume, and connect it to pulse oximeter to guide the heart rate response to resuscitation. Once you give positive pressure ventilation, you have to connect it to oxygen. How much oxygen you started for resuscitation based on the gestation age. If the baby less than 28 weeks, you have to start it with 30% oxygen. If the baby between 28 and 31, I have to start at 21 to 30% oxygen. And we'll titrate the oxygen up and down based on the need of the oxygen saturation. And our target oxygen saturation, you see the 10-minute oxygen target saturation. In the first minute we need 60 to 65, but our target in the 5 minutes it will be 80%. This target in the delivery room is different from postnatal. This is our target saturation at the 5 minutes. It will be 80% or above. And you can titrate the oxygen based on the condition and the baby requirement. It's okay, you give positive pressure ventilation and the patient is not improved and by assessment, so you have to intubate this patient. So the patient need intubation. What is the indication for intubation? If the patient not respond to positive pressure ventilation after corrective ventilation steps and Mr. Soba, in special consideration like the diaphragmatic hernia or premature babies, or are going to give in the surfactant or all of this. So this patient is not improved with positive pressure ventilation, and you did corrective ventilation step and you did Mr. Soba and all of this, and the patient is still not improved. You have to intubate this patient, and after at birth and consider only for those not respond to above measure. It's not respond to above measures, and also early intubation. And once you intubate the patient, you have to give surfactant. This is the indication for surfactant. What is the indication of intubation? What is the indication for surfactant? Indication of intubation: if the above measures is failed, you have to intubate the patient. And if you give both pressure ventilation and corrective ventilation steps and Mr. Soba, and they are going to give in surfactant, this is the time to intubate these patients. You have to intubate this patient, and also you have to intubate from the start if the baby having severe RDS. What is the meaning of severe RDS? This chest retractions and high oxygen requirement Surfactant may be actually required for babies who demonstrate clear sign of severe RDS. Severe sign of RDS. What is the severe sign of RDS? Chest retraction and high oxygen requirement. So this is the delivery room stabilization. Delivery room stabilization is four issues. So the antenatal, it was 4, and delivery room stabilization 4. First one, delayed cord clamping. The second one, you have to thermal regulation or maintain temperature of the baby. The third, you have to assess your patient If the baby is breathing but labored breathing and maintain saturation and heart rate more than 100, you put him in CPAP. And how much oxygen you started based on the gestation age. Less than 28, I will start with 30. If more than 28 to 31, I will start with 21 to 30. Then adjust up and down based on the oxygen requirement for the baby, and accepted saturation at the time at 5 minutes, it will be 80 and above. 80 and above. So if the baby does not respond to above measure you give it to him, you have to intubation. So the intubation, if you give positive pressure ventilation for the baby and not respond to the previous measure and is failed the corrective ventilation step, and Mr. Soba or are going to give special consideration, especially in the premature, extreme premature babies, or you are going to give in surfactant, or some baby like the traumatic hernia, at the time you can intubate. This is indication for intubation. Or the patient from the start having severe RDS. How to define the severe RDS? Such chest retraction and high oxygen required. You have to intubate. Once you intubate the patient, you have to give surfactant, or when to give surfactant if severe RDS, based on the chest retraction and the oxygen requirement. So the 4 issues: delayed cord clamping, maintain the temperature, and the second, you have non-invasive ventilation like CPAP. If the patient is not respond to non-invasive, you can intubate and give surfactant. Our aim to avoid intubation, our aim to avoid mechanical ventilation, our aim to avoid any invasive procedure for the babies. So this is the 4 items to treat the baby in the delivery room or stabilization in the delivery room. The last, or this is the respiratory support and surfactant. Respiratory support and surfactant. For sure, the types of surfactant you give, animal-derived surfactant, should be used and given as early as possible in the course of the RDS. Treatment threshold when to give: if oxygen requirement more than 30 and CPAP pressure is reached to 6 or above, seem to be reasonable to give surfactant. So this is the indication of surfactant. If severe RDS manifested with severe retractions and oxygen requirement is increased, is more than 30%, and if they put him in CPAP and require CPAP more than 6 centimeter water, so this is the time to give surfactant. Shall we give second dose of surfactant? When to give the second dose of surfactant? When this patient is required the second dose of surfactant, actually if there is ongoing evidence of RDS. If there is ongoing evidence of RDS, like again, same, if the oxygen requirement increase, if the pressure increase, the lung volume is small, so this is, you can give the second dose of surfactant. If possible, administration. So if you are going to give the surfactant, better to give non-invasive surfactant. You have, if possible, don't give non-invasive surfactant. How to give this non-invasive surfactant? We call it less invasive surfactant administration. This is called LISA or MES, minimal invasive surfactant administration. If one skilled person can give this one without intubation, well and good, and should give for a stable patient only. LISA and MES and non-invasive or less invasive surfactant administration method should be given for stable, clinically stable patient on CPAP, clinically stable patient on CPAP, and should a skilled person to give this actually. With so this is a possible administrative surfactant using LISA method, and but only for babies is clinically stable on CPAP with worsening sign of RDS, and the clinical expertise should be given through this technique. So the indication for non-invasive surfactant administration, clinically stable patient, then start to oxygen requirement will increase, and should expert person to give this LISA method for surfactant administration. So if the patient actually you put him in CPAP and is not improved with CPAP, and even after you give the surfactant by non-invasive way, and still the baby deteriorate, and you decide to intubate this patient, if you decide to intubate, you have to what's call it ensure technique: intubate, surfactant, then extubate. Don't give long time of intubation because it will affect the outcome. Our outcome and concern about the BPD and bronchopulmonary dysplasia, because the BPD and the oxygen toxicity and mechanical ventilation associated lung injury is the end result, the long-term outcome, the BPD. So we try to avoid the BPD, we try to minimize the intubation, try to minimize the invasive procedure, try to avoid the mechanical ventilation. So if I cannot the patient failed to maintain his respiratory condition or oxygenation, so I have to intubate the patient. But if you are going to intubate for short period, we call it ensure technique. Intubate, give surfactant, then extubate to CPAP or high flow nasal cannula or non-invasive post-operative ventilation immediately following surfactant. And judgment need to made individual baby will be tolerate. Shall this baby will tolerate or not tolerate? It's not actually is routine for all babies. You have this baby is tolerate this action or not tolerate. Say the patient you put him in CPAP non-invasive and not tolerate, what are you going to do? You have to intubate and give surfactant, or you can give the surfactant without intubation and check your baby tolerate this or no, because there is individualization between the babies. Actually, I put him in CPAP, the baby is not tolerate, so I give surfactant by Miss or Liza by non-invasive. If the baby tolerate this procedure and these issues, well and good. If not tolerate, I have to intubate. If you intubate, don't give intubation long time, don't give mechanical for long time, so you have to give ensure, then extubate. If the baby tolerate this, well and good. If not tolerate, you have to continue the mechanical ventilation. But if you continue the mechanical ventilation, should be in short period to avoid the chronic lung disease or bronchopulmonary dysplasia. And all this management depend on the tolerability of the baby and the clinical stability of the baby after you give the support. You give support, the baby tolerate, well and good. If the baby is not tolerate this support you give, you have to escalate your support. If tolerate this, well and good, but try all the time to be non-invasive. Try to avoid what's called intubation, mechanical ventilation. Try to avoid long time ventilation to avoid to decrease the incidence of the bronchopulmonary dysplasia. So if the patient actually intubated and surfactant may be so the patient actually you have to judge based on the tolerability of the patient. For those who actually require mechanical ventilation, so خلاص I give him CPAP, I give him non-invasive surfactant administration, and the patient is still requiring intubation, I intubate him, and so by ensure technique, then I put him in CPAP. The patient is not tolerate all this parameter, I have to ventilate him, so I will put him in the ventilation. But the aim of ventilation for short time as possible to avoid hyperoxia and hypocarbia and volutrauma. This is our fear from the mechanical ventilation. It can lead to hypocarbia, hyperoxia or volutrauma, and this will affect the lung and lead to chronic lung disease. So this may be best achieved, and if you put him in the mechanical ventilation, we said to have to be in short period and try to avoid hyperoxia, hypocarbia and all of this. And also, if you put him in the ventilation, you put volume target ventilation. Put him in volume target ventilation. This is the best modalities of the ventilation right now, to put him in volume target ventilation. And saturation alarm should be limited between 89 and 95. 89 to 95. The accepted saturation 90 to 94. But the alarm, it will be one less and one above. It's 90 to 94. It will be the alarm. It will be 89, and the alarm it will be 95. So this is if the patient requires mechanical ventilation, you have to short time, you have to avoid hyperoxia, hypocarbia, and avoid volutrauma. And also you have to choose the modes of the ventilator. It will be best for lung protective strategy. It will be volume target ventilation, and you have to set the oxygen saturation requirement or acceptable oxygen saturation and the alarm. Acceptable oxygen saturation 90 to 94, and the alarm it will be 89 to 95. So we finished now the ventilation. So I have to give the methylhexanthine or caffeine therapy. It may be used routinely to minimize what in need for ventilation. Caffeine therapy, there is two benefits to call it CAP trial. The most caffeine and the prematurity. Actually, there is two benefits to avoid apnea, prematurity, and failure of extubation, and also to minimize the need for ventilation. So you have to give caffeine to minimize the need for ventilations. Baby should be maintained on non-invasive respiratory support is preferred to mechanical ventilation. We prefer non-invasive better than mechanical ventilation if possible. If possible, and the baby tolerated. If possible, you can. Or if the baby tolerate, you can put him non-invasive better than the invasive. After 1 and 2 weeks, systemic steroid should be considered to facilitate extubation if the baby remain in the ventilation. This is the most important. It's called DART protocol. DART protocol, dexamethasone trial. If the baby is in mechanical ventilation for 1 week or 2 weeks and it's difficult to extubate him and having early BBD and require high oxygen and high mechanical ventilations and you cannot extubate, so we'll try with him postnatal steroid. And postnatal steroid actually it's a proof benefit for decrease incidence of the bronchopulmonary dysplasia, and this all to facilitate extubation of the baby from the ventilation. We give caffeine, we give a postnatal steroid, all this to facilitate the extubation. And also caffeine, it will help to prevent apnea prematurity and to prevent extubation failure. Premature baby receiving oxygen should oxygen target saturation between 90 to 94, and to achieve this you have to suggest alarm, as we mentioned, between 89 to 95. So this patient in the respiratory support and surfactant, you have to give surfactant, animal derived surfactant. If the patient require more oxygen, 30%, and he's in CPAP and require more than 6 centimeter water, so this is or the baby is require intubation, you have to give surfactant. Shall we give the second dose of surfactant? Yes, if there is ongoing evidence of RDS, you can give the second dose of surfactant. So this is the surfactant. If you are going to give surfactant, better and if possible to give by non-invasive procedures or a non-invasive administration method. We call it LISA and MES. LISA is less invasive surfactant administration or minimal invasive surfactant administration to avoid intubation, to avoid invasive procedures, because this invasive procedure and intubation actually it will harm the baby. It will lead to poor long-term outcome for this baby. So try to avoid intubation as possible. Baby is in CPAP, is require surfactant. You can give surfactant by non-invasive procedure, and this will be if the patient clinically stable on CPAP and oxygen requirement increase and worsening the sign of the RDS. So the clinician is experienced in the technique. You have to give this ELISA. So the indication for non-invasive surfactant or LISA or MES, patient clinically stable and started to deteriorate or there is worsening of the sign of RDS, you can give the surfactant by non-invasive procedures. If the baby is not tolerate the non-invasive surfactant and still deteriorated more and severe RDS, retraction, oxygen requirement is increased, and you have to intubate the patient and you give the surfactant by intubation, you have to do ensure technique. Intubate, surfactant, then extubate. Extubate to CPAP or high flow nasal cannula or non-invasive post-operative ventilation immediately following the surfactant, and adjust. After that, you have to adjust it based on the individualization of the baby will be tolerate or the tolerability of the baby. This action depends on the tolerability of the baby. The baby tolerate this to put patient in short technique, intubate, surfactant, extubate, put in CPAP. If tolerate this, will end good. If not tolerate, you go for the next step, and this is the mechanical ventilation. So you give surfactant. If you can give surfactant without intubation, will end good. If you cannot, you can give by ensure technique. Just only intubate surfactant, then extubate immediately if the baby tolerate. If the baby is not tolerate this maneuvers to intubate, surfactant, extubate, and you have to give him mechanical ventilation. It's our aim to be short time if possible to avoid hyperoxia and hypocarbia and volume trauma. And if you put him in mechanical ventilation, should be in shorter time, and you have to choose the best mode, volume target ventilation, and you have to set the saturation acceptable 90 to 94, and the alarm it will be 89 to 95. For sure we need to give 2 medications postnatally, caffeine to facilitate the extubation, and postnatal steroid if the baby require mechanical ventilation for more than 1 and 2 weeks of ventilation and difficult to extubate him, so or there is early sign of the BBD. It will help, actually postnatal steroid, it will help to decrease the incidence and proven benefit to decrease the incidence of bronchopulmonary dysplasia. So we need, why we need to give postnatal steroid? To facilitate the extubation and to decrease the time of ventilation of this baby. And if we mentioned the saturation, accepted saturation 90 to 94, and the alarm it will be 1 less and 1 above, it will be 89 and 95. This is the respiratory support and surfactant. Supportive measures maintain baby temperature, should be the normal baby temperature 36.5 to 37.5 all the time, because the people actually concentrated during the delivery room and will maintain the temperature. But our KPI now, or quality indicators now, to maintain, and the new guideline of the NRB, to maintain the temperature of the baby throughout the resuscitation and after, and even the beyond the resuscitation. You have to keep the temperature between 36 and 36.5 and 37.5 all the time. This is the most important, all the time. So the supportive care, you have to maintain the temperature. The second issue, you have to start the parenteral nutrition immediately with amino acid and lipid in initial fluid, and volume it will be 70 to 80 ml per kg per day, and for most of the baby, and restrict sodium during the early transition period. So if the baby, once you deliver, you have to start TBN immediately. During the daytime, you can use carbohydrate and or dextrose and protein and lipid, but if the baby is delivered at night, it's difficult to provide the TBN, so we call it a starter TBN, just only protein and carbohydrate or dextrose only. This could be easy and ready made. Actually, you can start it at night. This is the nutritional support for feeding, enteral feeding, and you have to encourage the mother for expressed milk actually to be started on day 1 if the baby is stable. So if there is contraindication for feeding and for the first day, no, you have to start the feeding from the first day if the patient hemodynamically is stable. The second issue, antibiotics should be judged and stopped early when the sepsis is ruled out. So you have to take septic up and start antibiotic, and you continue for 48 to 72 hours. If no evidence of sepsis clinically, patient is stable and the laboratory was normal and the culture came negative, you have to stop. Don't give antibiotic for long period, because if you give the antibiotic for more than 5 days, it it will increase the incidence of late onset sepsis, maybe the late onset sepsis, and maybe lead to increased incidence of NIC, and also would increase the resistance and all of this. Antibiotics. So the blood pressure should be also monitored regularly. Aim to maintain normal tissue perfusion. If necessary, use the inotropes or volume expander, and the hemoglobin should be maintained at acceptable level. And protocol for pain management. Actually, if you have to check the baby is comfortable or not comfortable, and consider to give non-pharmacological management to minimize the perceptual pain, and you can give pharmacological management for invasive procedure. So pain, you have in your unit having pain protocol management. If the baby is non-invasive procedures, you can give non-pharmacological management. If there is invasive procedure, you have to give pharmacological management. So summarize the supportive measure. You have to maintain the temperature. You have to start the TBN from the first day. You have to start the feeding from the first day. You have to take septic workup, start the antibiotic, and you will be shortly within 48 to 72 hours if no risk factor. And you have to monitor the blood sugar and the blood pressure to maintain the normal tissue perfusion. If the patient need volume expander or need inotropes, you have to start it, and you have to maintain the hemoglobin in acceptable level. Pain management. You have to advocates pain protocol management in your unit. If the patient not in an invasive procedure, you have to give non-pharmacological treatment. If he's in an invasive procedure, you have to give pharmacological management, to call it opiate for this patient, like morphine and all of this. This is the summarize of the management of the RDS. In summary, short in summary, it will be perinatal and during the delivery room, or perinatal. Once the baby will deliver, you have to stabilize the patient in the delivery room. Then postnatal in the NICU. Then supportive measure. We said perinatal, it will be for, first of all, you have to refer the patient if beyond your capability, and if the patient having RDS should go for center can deal with such cases. And you have to start antenatal steroid for lung maturation, anticolytic to give time for transfer, or give time for the steroid to work. And also the fourth thing, the magnesium sulfate, you have to start it to do for improve neurodevelopmental outcome. This is the 4 issues, the prenatal. And another 4 issues in the delivery room, it's called NRB. Once the patient is called the NRB, so you have to delay the cord clamping, and you have to maintain the temperature and oxygen target saturation. Patient less than 28, you have to start at 30% oxygen. More than 28 and 31, you have to start at 21 to 30% of oxygen. Then assess your patient. If the patient is spontaneous breathing and maintain, spontaneous patient but labored breathing or difficult breathing, maintain his saturation and heart rate, you can put him in CPAP. You can put him in CPAP. If the baby is not maintained and require is apneic or heart rate less than 100%, you can positive pressure ventilations. You have to give positive pressure and assess your patient, and you put target saturation during resuscitation. It will be 80% at the 5 minutes, 80 and above at the 5 minutes. If the patient is not maintain his saturation and he's in severe RDS and there is indication to intubate the patient, you have to give the surfactant if there is evidence of severe RDS, like chest retraction and oxygen requirement. After that, after stabilization of the patient, you are going to shift the patient to NICU, or you are going to give the respiratory support and surfactant. The surfactant will give it. Actually, once you intubate the baby, you have to give the surfactant. If the oxygen requirement is more than 30% and the patient on CPAP and the beep is increased to more than 6 centimeter water, the second dose of surfactant you give it if there is ongoing evidence of RDS. Then if you are going to give the surfactant, better to give by non-invasive, call it lysa or mist. And you should be patient he's in CPAP and stable, then he deteriorate, and there is indication to give surfactant while he's in CPAP, and should export person to give this one. If cannot give and the patient is not tolerate this procedure, you have to intubate and give surfactant and extubate, to call it ensure technique. If tolerate this procedure, this patient, it's well and good. If not tolerate, you have to intubate. You go put him in mechanical ventilation. If you put him in mechanical ventilation, it will be short period, and try to avoid the hyperoxia and hypocarbia. And also you have to choose the mode. It will be volume, we call it volume target ventilation. It will be more gentle ventilation to avoid the BBD, and you have to set alarm limit between 89 to 95, and also you have to give caffeine to facilitate the extubation from the ventilation, to prevent apnea, prematurity, and failure of extubations. And also you have to give postnatal steroid called DART protocol if the baby is ventilated for more than 1 week or 2 weeks and there is a sign of early bronchopulmonary dysplasia, and you have to facilitate the extubation you have to give. And you set the oxygen saturation between 90 to 94 and the alarm 89 to 95. This is in the NICU. After the supportive measure, you have to maintain the temperature 36.5 to 37.5, and also you have to start TBN. If in daytime you have to with lipid, if the night time it will be started TBN carbohydrate and protein. And also you have to restrict the sodium and electrolyte in the transitional period. And you have to start feed from day 1 if the patient is stable and hemodynamically stable. And the antibiotic should actually take septic or common salt antibiotic, and will be shortly 48 to 72 hours if culture negative and the all indices within normal and no evidence of sepsis, and blood pressure should be monitored and maintained to keep the normal tissue perfusions. If necessary, use inotropes, and should hemoglobin will be maintained an acceptable level, and protocol of pain management should be adopted in your unit. If the patient not in invasive procedure, you have to give non-pharmacological management like dextrose and all of this, or sucrose. And if the patient having are going to do for him invasive procedures, you have to give pharmacological management like opiate. At the end, I would like to pray for my colleagues is going for Arab board and Saudi board, Jordan board and Egyptian board, and our colleague in the neonatal fellowship. أسأل الله رب العرش العظيم أن ينجح كل زملائنا داخلين الخبرات، وأن ييسر أمر كل طبيب حضانة في الحضانة يساعد طفل في النجاح بإذن الله. نسأل الله أن يعينه الله سبحانه وتعالى على ذلك، وأشكركم والسلام عليكم.